Good evening, ladies and gentlemen. A very warm welcome to the last day of the physicians course run by the Heart Failure Association of India and the European Society of Cardiology Heart Failure Association. Today we have four important sessions. The first one is the recap of the previous sessions. Then it will be followed by a talk by Professor Andrew Coates from the European Society of Heart Failure. And subsequently, Dr. Tiny Nair will give a talk of the heart failure management. And subsequently, we have a panel discussion on the whole program which we have conducted. The last item will be the post test, which will be a link will be provided to all the participants, and you can take the test. I will provide the details of the test, how it has to be done, later towards the end of the program. So over to you, Dr. Bhagirath, for the recap of the previous session. Thank you.
Good evening, everybody. I'll start with the recap of day 4 because that was also supposed to be covered today. So first will be the recap of the day 4 proceedings and then the recap of the day 5. So the first talk was Peripartum Cardiomyopathy by Dr. Ambuj. So he started off with the definition, that is development of heart failure in the last month of pregnancy or within 5 months post-delivery, absence of identifiable cause and no previous heart disease. However, additional criteria were added on, that is LV systolic dysfunction, fractional shortening less than 30%, EF less than 45, and LV end diastolic diameter of more than 2.7 centimeter per meter squared. An interesting point was that LCIM modified the definition to include the second and the third trimester of pregnancy also. So as it stands today, the peripartum cardiomyopathy encompasses second, third trimester of pregnancy and immediately 5 months post-delivery. Signs and symptoms, similar to any other form of heart failure. Thromboembolism may be the first manifestation, and we can find LV thrombus too. Standard investigations, cath, MRI, biopsy, it's institutional protocol whether to do it or not. The highest incidence is seen in developing countries. Nigeria has the highest incidence. Indian incidence is 1 in 1,374. Afro-American ladies, older, multi-gestational are often the targets, and the TTN and the BAG3 gene are incriminated as per the genetic studies. Treatment, guideline-directed therapy, as mentioned here. Anticoagulation is often necessary, especially those who have atrial fibrillation, LV thrombus, or for those who are on bromocriptine therapy. Bromocriptine therapy at present, as per the guidelines, it's class 2B, level of evidence B. There's also a passing mention of requirement of ICD or LVAD or cardiac transplant depending on the duration and also whether the patient has not recovered over a period of time, that is a timeline of more than 6 months. And breastfeeding, earlier guidelines said it should not be done, but now the guidelines strongly recommend breastfeeding, and it has even been seen that breastfeeding mothers recovered faster. A major question was about subsequent pregnancy. Half of them recovery is less than 6 months, and for those who don't recover in 6 months, 5-year mortality is very high. Poor prognostic factors are finding a thrombus, RV dysfunction, and raised biomarkers. Subsequent pregnancy, if the patient has recovered, EF is normal, then the outcome is better. But if there's LV dysfunction, it is to be strictly discouraged. Management of subsequent pregnancy and delivery is multidisciplinary, and contraception and counseling form a very important part of management. Next up was the talk on arrhythmia-induced cardiomyopathy, tachycardiomyopathy by Professor Rakesh Yadav. Definition, Gallagher, 1985, impairment of LV function secondary to chronic uncontrolled tachycardia, which is partially or completely reversible after normalization of heart rate and or rhythm. Kastner in 2005 added that dysfunction of either atria or ventricles due to high atrial or ventricular rates without structural heart disease. Now that's important. The incidence in atrial fibrillation is 25 to 75%, and also PJRT is 20 to 50%, and in atrial tachycardia it's about 10%. Both supraventricular and ventricular arrhythmias can cause it. Factors contributing are the type of arrhythmia, the heart rate, and the duration. So, in summary, persistent heart rate of more than 100 per minute, lasting more than 10 to 15% of each day, and the atrial rate being more than 150% of that predicted for age, all of these contribute to tachycardiomyopathy. Another mention on the PVC burden: if it is more than 16 to 24%, longer duration, multi-form PVCs or NSVT, all of them can contribute to tachycardiomyopathy. There was a very interesting article by Bhushan and Ashirvadam, who said that more than 20,000 PVCs per day in young individuals without abnormal cardiovascular substrate, and even PVC from fascicles or outflow tract, can all contribute to tachycardiomyopathy. Echo features are just like any dilated cardiomyopathy. Exact cause is not known. Many postulates and molecular level changes have been incriminated. Neurohormonal activation further worsens the heart failure. One point of note is poor response to inotropes, and treatment is heart rate normalization. There are two types of tachycardiomyopathy. This was given by Fenelon in 1996, the pure and the impure type. Next was a wonderful discussion on chemotherapy-related cardiomyopathy by Dr. Sanjay Mittal. So, cardiac involvement in chemotherapy can be in the form of arrhythmias, thrombophilia, PAH, pericarditis, myocardial ischemia, and LV systolic dysfunction. Most notorious drug is doxorubicin, especially in doses of 700 milligram per meter squared. Incidence is almost half, that is 50% of the patients. Two types of myocardial toxicity: type 1, there is myocardial necrosis. This is often seen in doxorubicin and it is irreversible. Type 2 is the LV dysfunction where there is no necrosis. It's common in trastuzumab and it is reversible. The definition of cardiotoxicity is decline in LVF by more than 10%, 10 absolute percentage points with a value of less than 50%. This is definite cardiotoxicity due to chemotherapy. Probable, the definition is decline in LVF by more than 10 absolute percentage points with a value of more than 50%. And possible cardiotoxicity is decline in LVF by less than 10 absolute percentage points with a value of less than 50%. So these are defined criteria that is now available. Detection: standard protocol, echo, Muga scan, MRI, biomarkers. Evolution, how it happens: first there's cell injury, then there's deformation, then cardiotoxicity, and then heart failure. If you pick it up at the cell injury stage by frequently monitoring the biomarkers, the chances of stopping or modifying the chemotherapy and recovery is much better. Management: identify the high risk, you need to do serial echo monitoring, follow-up. The low risk is after 4 cycles. Moderate, when you have moderate risk, it is after every 2 cycles you need to monitor the patient, and high risk you need to modify after every cycle of chemotherapy. Treatment: limit the cumulative dose, treat comorbidities, and look for alternative medications, and also add standard guideline therapy. ACE inhibitors and carvedilol is seen in responders. 42% within 4 to 6 months have recovery of LV function. Early diagnosis, better response, and useful echo parameter is GLS to monitor the cardiac function. Next was a talk of iron deficiency in heart failure and its therapy. The update, current update 2021 by Dr. Stephen Anker. Absolute iron deficiency: reduced iron stores, serum ferritin less than 30 microgram per liter. Functional iron deficiency is disturbed iron metabolism in bone marrow. Serum ferritin is 30 to 99 microgram per liter, or serum ferritin of 100 to 299 microgram per liter, and TSAT of less than 20%. Anemia definition: less than 12 grams per deciliter. Iron deficiency with anemia is a double problem that we have to deal with. In the treatment, we have to avoid dextran iron because it can cause anaphylaxis. Best is to give carboxymaltose because it can be given in higher doses. Dose of IV iron as per the clinical trial data is 2000 milligram per year as per the requirement. IV iron beneficial even if in heart failure patients without anemia, so it's not really necessary for patients to be anemic. Strong reduction in morbidity and mortality. The AFFIRM AHF study showed that there is reduced heart failure hospitalization and cardiovascular death. Adverse events are the common ones: infection, diarrhea, hypophosphatemia, and so on. Iron deficiency is underdiagnosed and undertreated, and this can definitely turn around the outcome in management of heart failure. Diabetes, dilated cardiomyopathy, and normal coronaries. Current insights by Dr. Abraham. Most common cardiovascular complication of diabetes is heart failure. More autonomic dysfunction, pulmonary dysfunction, diastolic dysfunction, and worsening symptoms are seen. High fasting glucose, early diabetes onset less than 45 years, and high waist circumference. These are the patients who had a high chance of developing heart failure in the category of diabetes. Quarter of heart failure cases did not have a vascular event at all. Diabetes with heart failure, the 1 year mortality is 20%, which means that 1 in 5 dies. So that is the importance and relevance of this particular topic. Revascularization, where possible, will improve survival, and you also have to treat comorbidities. So diabetic cardiomyopathy, defined as the presence of diastolic or systolic dysfunction in a patient with diabetes without coronary artery disease or hypertension or valvular heart disease. So these components should not be there. Mechanisms of diabetes and heart failure: there's either coronary artery disease, hypertension, diabetic cardiomyopathy, extracellular fluid volume expansion. So you have to look for diastolic dysfunction on echo. Newly detected diabetes, 20% have subtle LV systolic dysfunction. If this is picked up early, treatment can be better. A very interesting point made by Dr. Abraham was the 4-drug regime, that is beta blockers, SGLT2 inhibitors, the angiotensin receptor blocker or ARNI, and MRA. So this is the 4 drugs. It acts by 5 mechanisms, and it adds 6 years of extra life. Of course, he also touched upon the other forms of treatment: ICD, CRTD, AF ablation, then the CCM, VAD. All of these are extremely useful in management of diabetic cardiomyopathy. SGLT2 inhibitors with ACE inhibitor gives additional 15 years of freedom from ESRD, that is end-stage renal disease, and also reduces cardiovascular death and hospitalization. Next, we move into the recap of the day 5 proceedings. The first talk was by me, heart failure and COVID. Prevalence of heart failure and COVID is 4 to 23%. Patients who have elevated troponin or BNP, or those who require high dose of diuretics, are at highest risk of either morbidity or mortality. Third heart sound, raised JVP, and hepatojugular reflux and pedal edema are common in heart failure, whereas diarrhea and muscle pain are common in COVID when you have concurrently both the problems, or you need to differentiate between the two. Mechanisms incriminated are increased oxygen demand, myocarditis, stress cardiomyopathy, and cytokine storm. Spectrum of disease can be RV strain, myocarditis, pericarditis, endocardial thrombosis, and so on. Investigations: lymphopenia, global hypokinesia on echo. MRI is a hallmark investigation, COVID myocarditis, and of course there's elevated biomarkers. Please note that if the troponin is high, the mortality is close to 70%. Treatment is as per standard lines: guideline directed therapy, favipiravir and remdesivir, invasive hemodynamic monitoring, and MCS as the case requires, inotropes where necessary, ventilation where necessary, renal replacement therapy, anticoagulation, antiarrhythmics, and so on. Two important points are: if troponin is more than 28 nanogram per ml, or if the NT-proBNP is more than 900 picogram per ml, these have a very, very high mortality risk. Of course, you have to follow vaccination protocols, telemedicine, family care, and also look after your physicians and nurses, because they are the COVID army that are running the show. Next is the SGLT2 inhibitors for heart failure by Dr. Stephen Anker. DPP4 inhibitors and SGLT2 inhibitors are the new approaches to reduce glucose. Not only regulate blood sugar, they're also good for kidney function, heart function, and overall metabolism. The Emperor Reduce trial and the DAPA-HF trial showed reduced cardiovascular death, heart failure hospitalization, and urgent heart failure visit. The Emperor Reduced also showed improved renal outcomes. Early benefit: you see benefit as early as day 12 when you introduce SGLT2 into the therapeutic regimen. Benefit is there whether the patient is diabetic or not. Now, this is an important point, and whether or not the patient is on other heart failure medication. So, just putting SGLT2 inhibitors alone made such a big difference. Emperor Reduced trial also showed 50% reduction in renal heart outcomes. NYHA class improved by 1 class within 4 weeks. And there's a 40% chance that this can happen. Quality of life, HbA1c, and other markers all improved. There was no hypoglycemia, no hypotension, and no ketoacidosis. So this seems to be the magic drug. Of course, downside, increased genital tract infections, which are of mycotic origin. So obviously they need to be treated, and better hygiene practices ensured minimal incidence of the same. 14% reduction in cardiovascular death, 20% reduction in heart failure hospitalization. Further, the Emperor Preserved Impulse EPMA kidney study and the Impact MI, all are trials that are eagerly awaited in the coming 1 or 2 years, wherein this data will also reinforce this particular drug. Where is SGLT2 inhibitors place in heart failure today? In every patient of heart failure. This is as per the soloist WHF data. There is no electrolyte imbalance, single dose is enough, no dose titration. So we look forward to the next guidelines where it's likely to be a class 1A recommendation in the management of heart failure. Next is the valvular heart disease and heart failure talk by Dr. Ajay Bell. Standard medications, guideline directed therapy, avoid hypotension in aortic stenosis and mitral stenosis. Influenza and pneumococcal vaccines have to be given as per protocol. Infective endocarditis prophylaxis for dental procedures involving gingiva. IE is not recommended for routine procedures like transesophageal echo, endoscopy, colonoscopy, and cystoscopy. Infective endocarditis prophylaxis must be given for prosthetic valves, including TAVI, which is relevant for us, homographs or annuloplasty rings, or even repaired or unrepaired congenital heart disease. Heart failure with reduced ejection fraction often has secondary mitral regurgitation. This is due to LV spherical remodeling with displacement of papillary muscles. This is best seen in the two-chamber view on echo. The regurgitated orifice area is best quantified on 3D echo. Medical management, MR reduced in 38%. So this is a whopping number, and this shows a very good response to medicines, and there is a better response in those who do not have a left bundle branch block. And also, if you introduce a CRT treatment, 43 to 63% of them had reduction in the MR. LA and LV are dilated out of proportion to the MR, and that's increased in the LA pressure. Stress echo is an excellent tool to assess secondary MR. In heart failure with preserved ejection fraction, MR is due to LA dilatation and has a good response to diuretics. Also make sure that the atrial fibrillation is controlled. The MITRA FR study showed that the MITRA clip did not improve mortality, whereas the COAP trial showed decreased mortality and lower hospitalization. Obviously, it was related to patient selection. Lastly, tricuspid regurgitation. It is functional in 90% of the cases. In all the valve surgeries, this has got the highest mortality. So it should be, surgery should be offered only when there's no other option. Hypertensive TR is the way in which it is perceived. TR feeds more tricuspid regurgitation. Long-standing atrial fibrillation with right atrial enlargement is often found. Long-standing TR also causes cirrhosis of liver and renal failure due to the back pressure, and these are added causes that increase the morbidity and mortality. The way to treat is probably tricuspid annuloplasty, and repair should be done with, along with left heart surgery where possible. Surgery for TR, the mortality is in upwards of 25%. Percutaneous interventions are gaining ground because of the high surgical mortality. Coaptation devices, annuloplasty devices, cable implantation, tricuspid valve percutaneous replacement are all for the high-risk patients. Thank you, everybody.
Thank you, Bhagirath, for that wonderful recap of the previous 2 days. Now, I invite the chairpersons, Dr. Vishal and Dr. Sandeep Bansal, to take over and proceed with the other 2 talks.
Thank you, Dr. Harikrishnan. We now go on to the agenda for today, which is we start with the exercise in heart failure, which will be presented by Professor Andrew Coates. And Dr. Andrew Coates does not need any introduction here because he's very well-known figure in among Indian audience. He's a very sought-after speaker, and he's the current president of the HFA of the ESC. Professor Coates, please.
Thank you very much. Very kind introduction. It's my great pleasure to be here with you. And I just share my screen now. find the right talk. There we go. Is that showing up full screen?
Yeah, it is.
Okay, thanks.
Yes.
So I'm Andrew Coates, as heard. I'm president of the Heart Failure Association, and I've been practicing heart failure cardiology for over 30 years. And my first passion, research interest was on exercise in heart failure. So it's a great pleasure to give the talk on this particular topic here in my declarations. What led me to that is the observation that we and others have been making in the late 1980s and early 1990s, that our conventional explanation for why patients with heart failure limited exercise was that they got short of breath because their lungs got congested, and they got tired because their blood pressure fell because of poor cardiac output. If they were true, then you would expect a relationship between a global measure of left ventricular function, such as ejection fraction, and objective exercise intolerance. That's best estimated by cardiopulmonary exercise testing, evaluating peak oxygen consumption. However, we and others found there was no correlation whatsoever, that a patient could have mild heart failure as regards to ejection fraction, but very severe limitation to exercise as measured by peak oxygen consumption, or paradoxically, they could have extremely poor left ventricular function with ejection fractions below 10% with relatively normal exercise tolerance. So although the damaged heart muscle was causing heart failure, something else was becoming the limiting factor to exercise tolerance. So we set out over many years to investigate what that might be. And the first thing we looked at was other muscle. Here we see two patients. On the left, a 50-year-old heart failure patient, on the left, a 50-year-old normal patient, on the right, a 50-year-old male heart failure patient. And this is the skeletal muscle biopsy taken from the quadriceps muscle. As you see, it is grossly abnormal with a reduction in fibers, a shift in fiber type, and substantial fiber atrophy. There are many other abnormalities. We began to look at that in vivo using magnetic resonance spectroscopy. And here during exercise, we could measure energy consumption by the muscle. You see a normal subject and a heart failure subject are relatively similar in terms of phosphocreatine, high energy phosphate stores, and pH. At submaximal, at maximum peak exercise, you see that the results are similar, but this occurred at a much lower level of exercise. So it matched exercise workloads. Heart failure patients had a very early acidification and a very early depletion of high energy phosphate, particularly phosphocreatine. And we were set out to try and evaluate the cause of that and the significance. Through many years, we and others demonstrated substantial abnormalities of skeletal muscle in all patients with heart failure, whether it be ischemic or dilated cardiomyopathy. There was a substantial loss of bulk. They could lose more than 50% of their skeletal muscle quite quickly. There was abnormal perfusion, both in gross terms and per unit muscle mass. There was early muscle fatigability, a shift in fiber type away from 2A towards 2B, selective atrophy of 2A fibers, abnormal metabolism, whether we measured by magnetic resonance spectroscopy, biopsy, or by metabolic turnover studies. There was apoptosis and inflammation within the skeletal muscle, and deficiency of growth factors, particularly IGF-1, within the skeletal muscle. That, of course, could explain muscular fatigue, but we knew that one of the hallmark symptoms of chronic heart failure was shortness of breath. So we wanted to evaluate the sensation of shortness of breath, and it's very hard to evaluate that. So we turned to something that's highly related to dyspnea, and that is ventilatory inefficiency. The more you breathe, the more short of breath you feel. And we looked at cardiopulmonary exercise tests in patients with heart failure and related the rate of CO2 production at the mouth, which should be driving ventilation via the chemoreflexes, and the rate of resultant minute ventilation. And you see there is a straight line relationship between the rate you're producing carbon dioxide and the amount you breathe. But as you get more and more severe heart failure, that slope is increased. So the patient with heart failure breathes 2 or 3 times as much for the same amount of CO2 being produced and driving ventilation as a person with mild heart failure. And no one had a good explanation for why these patients were apparently very sensitive to CO2 and were in fact hyperventilating. Their arterial CO2 levels were actually falling, so they were breathing more than they technically needed to. We began to investigate that, particularly with my colleague Massimo Piepoli in Oxford at the time, in the late 1990s, and studied a little studied reflex called the ergo reflex. That is a reflex that senses the metabolic state of skeletal muscle in a patient, which travels up the lateral spinothalamic tract and affects both sympathetic and parasympathetic outflow, but also, we discovered, had an input to respiratory control. We studied this ergo reflex by some elegant experiments where we included circulation after exercise and evaluated the ventilatory response, the breathing response to activation of these muscle reflexes. And as you see, as you get more and more severe heart failure, there is a substantial increase in the ventilatory reflex response to muscle work in the periphery, in this case leg, but also arm muscle. So that led us to the conclusion that if muscle is abnormal in heart failure and it explains fatigue, but also could explain exaggerated ventilation, shortness of breath, it's possible that if we could improve the muscle, we might improve the patient. So although at this time the textbook said that exercise was contraindicated in heart failure, we did the world's first controlled trial of exercise training in chronic heart failure, patients on the transplant waiting list. We had 17 patients here, published in 1992, and you see that uniformly the patients increased their exercise duration during a training phase, and 8 weeks of detraining reversed that. So we had a reversible ability to increase exercise tolerance in patients with severe chronic heart failure waiting for transplantation simply by exercise training. We did a lot of ancillary studies, and most of this benefit appeared to be peripheral, improving skeletal muscle function and, to a smaller extent, skeletal muscle blood flow. We and others did a lot of then small, intense exercise training studies in chronic heart failure after this period in the 1990s and early 2000s. And we found there was a small increase in cardiac output, but it was mainly due to reduction in systemic vascular resistance or total peripheral resistance. There was a reduction in heart rate and an increase in stroke volume and a relative increase in leg blood flow due to increased capillarity of the skeletal muscle in the leg. There was improvement in endothelial function with improvement in flow-mediated vasodilatation, which we think is due to improvement in the endogenous nitric oxide system. And there was an increase in skeletal muscle capillarity as measured on biopsies. There were also direct skeletal muscle effects, such as an increase in cross-sectional area, altered fiber proportions back towards normal, an increased peak work rate of the muscle, increased strength and endurance, and reduced fatigability. There was improvement in oxidative metabolism and aerobic enzyme activity, and an increase in ATP resynthesis, delayed in the anaerobic metabolism, reduced lactate accumulation, and reduced high-energy phosphocreatine depletion. There were also changes in fiber atrophy improvement, capillary density, and in the mitochondria themselves, showing an improvement in mitochondrial structure and function. We went back and looked at the ergo reflex again. You remember the small muscle reflex fibers that drive both ventilation and sympathovagal changes. And we saw there, with circulatory occlusion, you maintain this stimulation to ventilation. And that's the difference between an occluded and a released circulation. That's the component of ventilation that's driven by the muscle ergo reflex. When we compared the detraining state, there was a substantial ventilatory component due to the muscle reflex compared to the trained state, where that went towards what we saw in normals, showing that we could reduce the activity of this muscle ergo reflex by training the peripheral muscle. And it didn't require whole body training. Single limb training could improve that reflex. We then studied the autonomic effects of exercise training and showed an increase in heart rate variability, a simple measure of sympathovagal balance, high frequency heart rate variability, which is a measure of vagal function, and improvement in the high frequency, low frequency ratio, which is a measure of sympathovagal balance. We saw an increase in baroreflex sensitivity, a reduction in chemoreflex sensitivity, and a reduced ventilatory response to CO2. That was that slope we saw earlier during an exercise test. There was also a reduction in radioactive catecholamine turnover, showing a reduction in true sympathetic activity, and a reduction in circulating and skeletal muscle immune activation. So we decided to do a meta-analysis of all these modest-sized small trials and showed, this was published in 2004, there was a significant improvement in survival. P was only 0.015, and these were small studies in very dedicated centres with a particular interest in exercise training and heart failure. There was also a significant effect on reducing death or heart failure hospitalisation. There was then an attempt to do a very large-scale study called HF Action, and that was about 2,000 patients, done mainly in the United States, because unfortunately we couldn't get the money in Europe. And that looked at all-cause mortality and hospitalisation as the primary endpoint and a series of fairly standard secondary endpoints. The study design there was fairly simple. It was randomisation 1-to-1, stratified by centre and heart failure etiology, with a median follow-up of 2.5 years, comparing training with usual care. The problem in retrospect was that some patients lose the willingness to keep going exercise for long term, and some patients randomized control actually hear about it and start training themselves. So we don't get long-term difference between these two groups. We saw very big early effects, and they gradually got less different with time. The primary endpoint was not quite significant, P.13. The adjusted baseline imbalances was significant, but technically this was not a positive trial, despite the fact the exercise group appeared to do better than the control group. Similarly, for cardiovascular mortality or heart failure hospitalization, just a little bit like the recent Paragon study, P.06, adjusted hazard ratio was 0.85, P.03. So it was borderline positive for this major outcome of CV mortality or heart failure hospitalization. But as I said, the problem was the two groups weren't that different in terms of their willingness to exercise late in the trial. There was, however, early on, up to 3 months and even up to 12 months, very substantial differences in exercise capacity, with a significant increase in 6-minute walk distance, shown there, cardiopulmonary exercise test duration, peak VO2, at 3 months and 12 months, we saw significant differences. Then people started saying, well, if training works in HFrEF with simple bicycle exercise, could we use new modalities of exercise, or could we train different types of patients? So one was another form of exercise, traditional Chinese exercise, Tai Chi, a study shown here from 2011, and showed that even this gentle exercise in heart failure patients could lead to an improvement in Minnesota Living with Heart Failure score in the group randomized to Tai Chi over 6 to 12 and even up to 48 weeks. Then people looked at other training regimes, such as the use of intermittent exercise, where a person is encouraged to do high-level exercise and then lower level rest and then high again. And intermittent actually led to significantly greater improvements in peak VO2 than continuous exercise, and that's something that exercise physiologists are aware of. And another review was comparing combined exercise, which is aerobic or movement exercise, with that of static or strength training. And the overall improvement in peak VO2 was higher on average in the patients who had the two forms of training, both strength training and aerobic training, compared to a single type. Then there was a vogue for training the respiratory muscles that could also be abnormal in heart failure, and a study looking at inspiratory muscle training in patients with heart failure. A review of these smaller trials shown here showed significant benefits in terms of walk test distance and peak VO2 by the use of respiratory muscle, training the inspiratory muscles by a forced inspiration against resistance, training the diaphragms and the chest wall muscles. Then there were new targets studied, such as what about other types of heart failure patient? This study here from colleagues in Liverpool looked at patient benefit from training patients with CRT in situ, the addition of a structured exercise training, fairly standard trial population, mean age 65 years. And what they found was a significant increase in peak VO2, a significant benefit in terms of NYHA class, as well as hemodynamic benefits in terms of ejection fraction and peak cardiac power output. That is peak blood pressure times peak cardiac output. Then it was taken even further, and patients with long-term ventricular assist device were also trained both in terms of whole body exercise and this inspiratory muscle training. And that led, this was my colleague from Greece, Stamatis Adamopoulos, showed that we can get an increase in peak VO2 in trained patients compared to controls. And these are all patients with implanted ventricular assist device. Of course, if it worked in HFrEF, it might also work in HFpEF. So a group looked at exercise DHF, exercise training in diastolic heart failure, with Burkett Piska, and they showed an improvement in diastolic function in patients with HFpEF in a pilot study, and in the main study, an increase in peak VO2 and maximal workload, along with confirmation of these improvements in diastolic function. A meta-analysis of comparative studies in HFpEF, there are not as many as there are in HFrEF, but a series of small studies, relatively small numbers, with relatively short duration, showing the consistent increase in ability to exercise, both in terms of exercise tolerance as well as quality of life using Minnesota Living with Heart Failure. However, the problems we have with exercise training is not that it doesn't work. It's not that it's not attractive for patients. It's just that we're not good at recommending it. We're not good at funding the programs and follow-up, and that patients aren't good at adhering to it over the long term. They can all see the benefit over 2 or 3 months, but then other illnesses set in. There are social difficulties, the need to come back to the hospital to get reassessed. All of those mean that patients tend not to persist with the training long term, despite the fact that you lose the benefit if you stop training. There is coming up very soon at the American College of Cardiology a very interesting study that will be presented for the first time, and that's called REHAB-HF, and it's answering a very important question because it's looking at a pragmatic training program in very much older patients with acute decompensated heart failure while they're still in hospital, patients with a high degree of frailty. The features of this trial are very attractive. It recruits elderly patients in hospital during an admission, very few exclusion criteria, far fewer than for a drug trial. They are required only to be able to walk 4 meters, which means there are many frail patients, and the intervention is a multi-domain rehabilitation program developed specifically to older, frail heart failure patients who've been hospitalized for acute decompensated heart failure. The exercise is designed to improve balance muscles, mobility, strength of leg muscles in particular, and endurance using reproducible, targeted exercise administered by a multidisciplinary team in the frailest elderly heart failure patients. We can't see the results yet, but they will be there in a couple of weeks' time. In summary, the present state of knowledge about exercise training for heart failure is that it does improve functional capacity, quality of life, and multiple risk markers and adverse pathological changes. It possibly reduces heart failure hospitalizations if the patient persists, and with no worsening and possibly an improvement in mortality. Emerging evidence suggests value with novel training programs such as the use of resistance training, inspiratory muscle training, and other types of training regime, in HFpEF as well as HFrEF, in elderly and frail heart failure patients, as well as those who are more easy to study in trials, and even during an acute decompensated heart failure admission. Thank you very much. Happy to take any questions or discussion.
Thank you very much, Dr. Coates. That was a very elegant talk, and it is my privilege now to invite my friend Dr. Tiny Nair to tell us. As I see, there are there are take-home and panel discussions at the end of the 2 talks. So I'd invite my friend Dr. Tiny Nair to tell us about long-term management of heart failure, because besides science, it is also the art of management of heart failure, and he's going to tell us about how to follow up, when to stop or reduce the drugs, and in general how to go about managing a patient on the long-term basis. Dr. Tiny Nair, please. Please
Thank you, Dr. Yeah, thank you, Dr. Sandeep, for that introduction. Give me a moment by the time I share my screen. Is my screen visible, and am I audible?
Yes.
Thank
Yes.
you. So we'll be discussing in the next 15 minutes or so about the follow-up strategies, uh, and also end up with talking about de-escalation of drugs in heart failure follow-up, my disclosures. Now the first thing is that home recharge. Home recharge is still truly challenging, whether we are talking about Tesla recharge at home, or whether we are talking about recharging our failed heart, and taking care post discharge at home. Uh, if we look into the basics of a natural history of a disease, for example, a cancer trajectory, we see that the natural history of a cancer patient usually starts, for example, years, months to years. It continues to be in that dotted line, kind of doing well. And then gradually, as things worsen, the cancer metastasizes, it gradually tends to go down and ending up with things that are bad. And that's the usual trajectory of not just cancer, but most chronic diseases. Heart failure is different in a way that not just that we have the disease goes for years or months in a steady downhill course, ending up with something bad, steady downhill course, but it is also punctuated by this gorgeous, and they are heart failure hospitalizations. And we today know that they're not just hospitalizations. Every time the person gets an acute pulmonary edema and comes to the hospital, he is ill, he is suffering. Not just that, his entire family is under stress, and there's a huge amount of social and economic burden associated with each hospitalization. And that's why the aim of heart failure treatment is not just to reduce heart failure death, but also to reduce heart failure hospitalization. Even if we can't slow down, stop death, or reduce mortality, if we can reduce those heart failure hospitalizations, you would have done at least something. Now, Dr. Javed Butler wrote this beautiful piece. He's from Mississippi. He wrote this beautiful piece on worsening heart failure trajectory. And he has very clearly shown that if you look at the natural history of heart failure and look at the proportion surviving, you see that by about 2 years' time, about 30% have died. 30% have died in 2 years' time. But what is even more interesting is that a large burden, about 50% of these events happen in the first 1 month or maybe 3 months' time. In fact, you see that first 30 days, the events are so high, and subsequently, the event rate just slowly goes up, which means it is most challenging to treat and look at the problems in the first 1 month or 45 days after discharge from hospital. And that is why we are focusing on post-discharge follow-up. One new interesting concept is home time after discharge. Well, we know that after discharge, between those hospitalization, patient of heart failure spends time at home. But what about quality time? He might not be admitted, but he might spend a lot of time in rehab, in care facilities, in the labs, in imaging facilities, and not have good home time. So if you look at the home time spent by the patient, it makes very interesting observations. For example, here in the x-axis you have death time to event time, means how long the person lived. And on the y-axis, you have home time, the quality home time where you have enjoyed this television, this popcorn, and been at home despite heart failure. And we see that those patients who lived for a short time, let's say 60 days, okay, on an average, they found that the home time was about 24 days. In contrast, those who have lived for about a year, 365 days, they have a home time of about 240 days. Okay, good, understandable, 10 times. But what is interesting, and often we fail to notice this, some of those unfortunate patients in that group of 0 to 59 days have spent 60 days, almost entire of their lifetime, in hospital, right? In contrast, you see the other end of the spectrum, where you see that the home time is low in a group of patients who have lived for 365 days with 240 days of good home time. So it is not just the lifespan, it is not just the duration of time that a heart failure patient lives. It is more important to focus on what could be their home time. And as we see that even people who have lived for, let's say, a period of an year, they might have very poor home time at the lowest end of the spectrum. That line is the confidence interval, right? Now, with that background, look at the present therapies. I always quote Graham Cole's beautiful article. Graham Cole is from the Hammersmith Hospital, Imperial College. He beautifully put how triple therapy today makes survival time triple. Many often physicians fail to understand that. If you look at the baseline and put a straight line there, and look at your ACE inhibitors, beta blockers, and angiotensin antagonists, MRAs, added each time, we see that the lifespan moves from there to there to there, actually triples. But how often do we understand that when we treat our patient in the hospital? So if we just start our patients on 3 therapies, RAS inhibitors, beta blockers, and MRAs, we practically triple their lifespan. And while we were talking about that, and this is the Indian guideline, which we wrote, a couple of dozen of our colleagues, we sat together, spent some time, and then finally we also said the same thing. RAS inhibitors or ARNI, beta blockers, and MRAs are a must for heart failure, right? But then came ARNI and SGLT inhibitors. And we today know that ARNI and SGLT inhibitors improve survival. So they have quickly become an actual part of the armamentarium of drugs that we use for HFrEF. Okay, so that's why today, for example, the beautiful editorial talks about what? Heart failure drug treatment, the fantastic 4, from 3 to 4. Okay, so we have graduated to 4. But let's pause and say here, this is the Trivandrum heart failure registry, entirely envisaged, done, led, and entirely the brainchild of Dr. Harikrishnan. We were a part of it, and we are proud that we have been a part of it. And we got the data, 1,200 patients, published in the American Heart Journal. Subsequently, the Trivandrum Heart Failure Registry, the small town of Trivandrum from where we come, came into the European Heart Failure Journal, the Indian Heart Journal, the International Journal of Cardiology, and the Journal of Heart Failure. We have learned a lot of new things from the Trivandrum Heart Failure Registry. But this is something that I always highlight. This was truly, truly something fascinating. If we look into that graph and look at the cumulative mortality in y-axis, cumulative mortality in y-axis, and try to see what happened to people who received guideline-directed medical therapy at discharge. By guideline-directed medical therapy, we talked about just 3 drugs: ACE inhibitors, beta blockers, and MRA. Those in the red line are those who received guideline-directed medical therapy. And look at that. They did so well. In contrast, the blue line are those who did not receive guideline-directed medical therapy. And they did bad. They had a 3 times higher mortality. So we need to ensure that our patients got at least 3 drugs. And the interesting point was 24% of our patients in Trivandrum Heart Failure Registry received GDMT at discharge, which means 76% of our patients did not receive GDMT. And we are proud that we provide world-class standard care in Kerala for heart failure patients, which shows that they don't even get 3 standard drugs, 76% of them, and there lies the challenge. Which means when we are talking today about 4 drugs, and we are unable even to give 76% of our patients 3 drugs, are we barking up the wrong tree? Are we barking up the wrong tree? Do we have a wrong strategy? So when we are talking about something like a GDMT, we are unable to cross it. And we are today talking about 4 drugs. So where do we actually set the bar for it to be right? Yeah, theoretically we do understand that 4 drugs is fantastic. All 4 lower mortality and improve survival. So whom should we give it? Everybody who tolerates it, right? But the challenge is, it is simply not possible in the Indian scenario to do that. So the challenge is, how do we tweeze out and how do we proceed? This particular data set of RICA heart failure comes from Portugal, Lisbon, very interesting data set, where they looked into the protocol-based follow-up program, where right after discharge at day 10, 1 month, 3 months, 6 months, and 12 months, the cardiologist visited the patient and ensured that his drug therapy is upgraded. And they tried to see, did that aggressive protocol-based treatment impact the prognosis and quality of life of the patients? And see what? It did work wonders. Let's look at ACE and ARBs. Okay, on the left, the golden bar is those who did not receive a discharge at baseline ACE-ARB. Gray and dark blue are low dose of subtherapeutic dose of ACE-ARB, and the blue is full dose. Look at that. On follow-up, once you have an aggressive protocol in place, you can raise the bar to a level where larger number of patients got full dose ACE inhibition or ARB, RAS inhibition. Same thing for beta blockers. Same thing for MRAs. Right, compared to the baseline, small blue bar, the number of people, the percentage of people who did receive guideline-directed medical therapy were significantly more. So one way would be, we can have an aggressive protocol-based follow-up. Second thing is, you would ask that, is that viable in India? So let us look into the cost factor. Now, one such paper is about the financial burden of heart failure, which is most important in India. It's a real challenge, and that came from Manipal Heart Failure Registry, India. They tried to look into and tweeze into the cost factor of financial burden of treating heart failure. A very interesting study. The blue aspect of that circle is index admission expenses, and the orange part of the circle is follow-up percentage of expense. So follow-up expense, orange, blue is index hospitalization expense. Look at that. If we split up the index hospitalization expense, we find that it is dominated by that color gray, which is medicines, devices, and procedures. Right? They form the bulk of the cost. But often we forget the follow-up. During the follow-up, you see that the orange part is maximum. And that is what? Readmissions. Which means if our strategy cuts down readmission, the treatment cost of heart failure in India becomes far more viable, far more healthier. Which means, yes, we have 1, 2, 3, 4 excellent drugs. But the way that we put our patients on drugs, the way we follow up, are not good enough to ensure that the population gets enough benefit. So that brings us to the most important question. How do we cherry pick those with poor outcomes so that we choose and give them at least those drugs which improve their outcome? Obviously, with the economic problem, with the social structure, we can't give 4 drugs to everyone. We would love to do that, but it's not possible. So how do we cherry pick? Okay, why not implantable hemodynamic monitoring? We have a huge number of implantable devices. We have OptiBall looking at the impedance. We have CardioMEMS, pulmonary artery pressure. We can heart pod, or we can have left atrial devices, laptop HF. But are they viable in routine monitoring in India? Obviously not. You'd say, okay, we today know that you don't really need to implant devices. We have wearable devices. Today is the era of wearable devices, where we are talking about hell of a lot of devices, wristwatches, smartphones, patches, headbands, everything. In fact, we have watches and devices. We have uh, rings, we have vests, everything to non-invasively monitor heart failure status, whether it's arrhythmias, whether it is fluid collection, whether it's impedance, everything can be monitored. And today, fortunately, we hold a cell phone in our hand, which has a tremendous power of analysis, not just picking up like, with a sensory input of camera, touch screen, fingerprint sensors. We have voice processors, microphones, but we have a huge array of accelerometers, gyroscopes to monitor whatever we want. And the analysis would give us a huge amount of data processing ability, and we can look into that. But the point is this is good to talk about in a forum and talk about the science. But understand that, for example, the US health spending is a 3.3 trillion US dollar budget, right? And with an 18% of GDP going to health budget, which amounts to about 11,000 US dollars per person. Okay. And then we are talking about India. Unfortunately, we have 1.28% of our GDP going for health, which amounts to what? About 85 US dollars per person. So all that these strategies that we devise for follow-up of heart failure has to be on ground and has to be matching with reality. Okay, we can't really put every person with an implantable device. Okay, we can put even a wearable device for everyone. It's simply not possible. So our tools are limited. And one of those beautiful tools, for example, I always think one of the most beautiful tools is one device at AIMS. Dr. Sandeep said, put it in print. It's a very beautiful Hriday card, a checklist for heart failure. These patients post-discharge are sent with the Hriday card. What is it? The beautiful, simple paper card, no electronics, and patient's name, IDs are there, and page 2 has his heart failure checklist. So simple checklist that the doctor on follow-up checks. Is the patient on ACE inhibitor? Is the patient on beta blocker? Is the patient on MRA? Is the patient on SGLT inhibitor? Simple, you can put as many as you want, so that neither the doctor nor the patient understand that he's missing out on anything. And the dose, whether he's correctly taking the dose. The next 3 pages, one is daily weight monitoring, to predict whether he is going to have a heart failure admission. You might say, well, this is not really sensitive. We know that the sensitivity of taking daily weight is less, but if we still pick up that there is an increase in body weight, we might be able to ward off a heart failure hospitalization by tweaking his diuretic dose. The next page talks about how to control your heart failure regarding weight management, salt management, diet, stress management, how far to exercise. And the last page about where you are, red, yellow, and green zone. And emergency numbers in case you are in trouble, how to contact the heart failure team. A simple 5-page booklet, but I think it makes a tremendous difference in the outcome of heart failure. Simple tools like a bathroom scale or a home blood pressure monitor or a pulse oximeter. Today, every home who can afford has a pulse oximeter because people are scared of COVID. And we can use these simple tools to try to predict and make our heart failure outcome better. The ASCEND heart failure trial showed that if you look at body weight change, for example, the ASCEND heart failure data, you see that 1 kilogram of increase in body weight equals to 16% increase in 30-day mortality and heart failure hospitalization. So simply if we tell the patient that do monitor your body weight daily, in case your body weight is increasing, do report to the heart failure team. I'm sure if we tell this to all our patients, we might pick up quite a few patients earlier before they come with orthopnea to the intensive care unit. Same thing reflects in the Everest trial. The Everest trial subset, which looked into the weight change and rehospitalization, very clearly shows that if you look at heart failure hospitalization, especially, for example, the first 60 days, you see that change of weight predicts heart failure hospitalization. These are simple tools, but then might be of tremendous help to all of us. we come to the last part of the therapy, and that is always asked in meetings as to how do we de-escalate therapy. This is important for India because this is a question that every patient comes and asks us. Doctor, these drugs are expensive. I don't have insurance. I'm paying from my pocket and I'm feeling fine, or my father is feeling fine. Can we reduce the drug slightly? Can we get a less expensive medicine? Can we go down on the medication dosage? What is the data? Now, a beautiful piece of information comes out from the dynamic trajectory study of left ventricle. This is a huge study. This is by Joseph Lupon from Spain, Barcelona. In fact, this is a 15-year study, 15-year study, where the authors have done echocardiogram for heart failure patients every year. So we know the natural progression of ejection fraction in heart failure. And what did this study show? It did show that the blue in non-ischemic cardiomyopathy and the red in ischemic cardiomyopathy, over a period of time, despite continuing treatment, the ejection fraction tends to slowly go down. And it tends to go down a couple of years before the study ended, right? This is more prominent in patients of non-ischemic cardiomyopathy. Now, when they split up the groups and tried to look into different etiologies, look at that. Idiopathic dilated cardiomyopathy, same pattern. Beyond about a period of 50% of the follow-up, it slowly tended to go down. Look at hypertensive cardiomyopathy, same pattern. Ejection fraction slowly tends to drop. Look at toxic cardiomyopathy, same pattern. Valvular heart disease, same pattern. So there is a tendency for the natural history of heart failure over time, the ejection fraction to drop despite continuing medications. What does it mean to us? Now, this is again, probably in this study, one of the most drastic drop was the blue line, heart failure with mid-range ejection fraction. The HFrEF is in the red. When you compare with HF mid-range ejection fraction, see that the drop is far more earlier. What does it mean to us? Which means it is challenging to withdraw, stop, or reduce dosage in HFrEF. The TREAD heart failure trial, which came last year, this is by the British Heart Foundation, they tried to look into this. Can we reduce cost by de-escalating heart failure therapy? 50 patients were taken up, and in this unique study, they tried to withdraw pharmacological treatment, ACE inhibition, beta blockade, and MRA in patients who had improved out of heart failure, who have recovered from dilated cardiomyopathy. And what was their definition of improvement? One, patients who became asymptomatic, patients whose ejection fraction rose from 40 to over 50, patient whose left ventricular end-diastolic volume normalized, and patients whose NT-proBNP biomarker was less than 250 nanograms per ml. So biomarker normalized, LV diastolic dimension volume normalized, ejection fraction improved to 50% and more, asymptomatic. So by all parameters, they are cured, right? And in these patients, they tried to see on withdrawal what happens. Do they go for relapse? And the definition of relapse was clinical evidence of heart failure coming back, ejection fraction dropping by more than 10% or going to below 50%. So ejection fraction dropping by more than 10% and going to below 50%. Increase in left ventricular end-diastolic volume by 10%. Decrease in left ventricular, increase in left ventricular end-diastolic volume by 10%. And 2 times increase in NT-proBNP and at least to more than 400. So increase in biomarker, increase in end-diastolic volume, and a reduction of ejection fraction by more than 10% with the clinical evidence of heart failure constituted the primary endpoint of relapse. So what happened on follow-up? We see that the x-axis is the months since randomization. 1, 2, 3, 4, 5, 6 months. It's a short period, 6 months. And the blue line, which you can see hugging the 0, is the control group, where they continued medication. The red, those who stopped medication. We see there's a 46% relapse rate on those whose drugs were withdrawn. So on withdrawal, compared to those who continue drugs, there is 46% chance of relapse. And in the second phase of this study, they took those 25 patients who were still continuing medications, they put them onto withdrawal group again and found there's an additional 36% relapse in the group once you stopped it. So 46% in the initial group and 36% in the subsequent group, which means huge number of patients tends to go into relapse once we stop or de-escalate medications in heart failure. And so the take-home message would be extremely cautious to de-escalate therapy. Unless there is a side effect, it is better to continue medications of heart failure, because heart failure is a progressive disease. And even when we continue to take medications, there is a progressive decline in left ventricular ejection fraction. So at the end, where are we in today's discussion? Conclusion number one, heart failure has an unusual natural history. Its sharp decline is punctuated by gorges of acute hospitalization, which add up to the burden of the disease, not just the stress, not just the mortality associated, but a huge socioeconomic burden to the disease. Second, early post-discharge period, the first 30 days would be the red flag period when most recurrences take place. Third, despite the benefits of 4 fantastic drugs that reduce mortality, the time spent by the patients at home, despite therapy, is short. The effective time where they can actually enjoy the television and popcorn is short. And the endeavor of all the follow-up therapy should be to improve on home time. Ground realities, available resources and toolkits, local toolkits needs to be checked. It is good that we have fantastic heart failure drugs. We have devices, but then one has to intelligently plan up an algorithm which is suitable for the local society. And finally, be extremely cautious of de-escalation, because de-escalation tends to recoil the problem. Thank you for your time and attention. I give back the podium to the organizers.
Thank you very much. So we need to proceed to the second session, and kindly guide us how to proceed. I don't see Dr. Das or Dr. Goho.
I think let's have question answers first. Then we can do that. What do you think, Hari?
Yeah, Doctor.
Okay, great.
Yeah,
Yes.
Dr. Bhagirath. Yeah.
My question to Dr. Andrew Coates. In a patient with chronic heart failure, when there is acute decompensation and then recovery, when would you reinitiate an exercise protocol?
Okay, when a person's acutely unwell, either from heart failure or some other illness, viral illness, temperature, you should stop the exercise for a short period, but try and keep mobility going. So if a person's had decompensated heart failure, as soon as they're no longer congested, then encourage limb movement, you can have passive movement, and they should be getting back to exercise before they leave the hospital. I think that's the lesson we're seeing, is you should not do intense exercise when you're unwell, but never leave it to get deconditioned. So just bring back gentle exercise, build up again slowly. You can do limb by limb, single exercise. It's complete bed rest that's dangerous, and that's only needed for a very, very short period.
In extension to this, many times when you do a 6-minute walk test, you have a crash cart ready just in case the patient has an event. So when you are having a proper exercise protocol, how do you manage this? Is it would you put an ICD for all patients, or selectively decide who gets an ICD or a CRTD?
Okay.
How do you manage this?
Okay. Well, I mean, we all know the indications for ICD. So anyone who's got a very low ejection fraction, or if there's documented risk VT, risk of resuscitated sudden death, then they need an ICD. In terms of exercise induced, We always do at least 2 supervised exercise tests under supervision in hospital. We evaluate whether there is exercise-induced ventricular arrhythmias. In the majority of patients, there aren't. Patients with heart failure are at risk of ventricular arrhythmias and sudden death, but actually in observations, it's over 840,000 hours of observed heart failure patient exercise. Exercise-induced sudden death is extremely rare, and it's been calculated that you're more likely to die in the 23 and a half hours of day you're not exercising than the half an hour you are exercising. So my recommendation is, unless there's an unusual feature in the patient where exercise actually triggers ventricular arrhythmias, then it is relatively safe. But you always do at least a number of supervised exercise tests before you recommend home exercise.
Yeah. I would like to ask a question, and not necessarily Dr. Coates, but any one of us could actually take that. You know that although yoga is catching up in the West, but in India there's a lot of things happening in terms of yoga. It is some of the things that are well known are that it helps in adherence to a particular lifestyle, possibly adherence to exercise also. So, would anybody recommend, or has anybody done any particular work in terms of using yoga as a tool in heart failure patients for adherence to exercise and adherence to lifestyle modification? I'm aware of data from India from a couple of groups in coronary artery disease, but specifically in heart failure, is there any data? I would like to understand, or anybody could take it, even if that's
Dr. Manchanda has done work on heart failure and yoga also, apart from coronary artery disease.
Okay, sir.
And his data shows that there is a substantial improvement, not just in feeling of well-being, but also psychologically they feel much better. There is gentle exercise which does the same things that Dr. Coates has been stressing. Also, they have a more positive outlook towards life, which goes a long way in promoting what Dr. Nair was also suggesting.
All right.
Yeah,
Does it really create trouble because it's an isometric exercise?
Not really. Yes, Dr. Coates wants to say something.
Yeah, well, I mean, isometric exercise is actually quite good. So you need to build up strength. But yoga, as far as I'm aware, I'm not a practitioner, but it involves breathing control. And there has been a lot of research on breathing exercises and slowing breathing. And that has substantial benefits in terms of sympathovagal balance as well. So I think there'll also be strong autonomic benefits of yoga potentially.
Yeah, that also has a benefit in terms of reducing the heart rate. We know one of the things, one of the targets that we have in heart failure is to come down to a lower heart rate, and the yoga tends to help in that. Are there any further questions?
I have a comment, Sandeep, if I may.
Sure.
You know, a recent analysis, not to necessarily do with our medical group, but of patients of, cardiac patients who follow yoga, follow the commonly practiced yoga, both seen on the television and followed in the society by Ramdev, and that includes two of the very important ones called Kapalabhati and Willow. They truly are a little sort of difficult ones. Do they make an impact on heart failure? Sandeep, you would have a comment?
No, I'm not aware of such a thing in heart failure. As I said, I was rather asking the question. My comment related to reduction in heart failure is in the usual patient. In fact,
yeah, because this is what the patients commonly practice. These are the ones which is truly being practiced in our population when they get out of the hospitals.
But there are different forms of exercises. I do a bit of yoga. It is supposed to increase parasympathetic activity and reduce sympathetic tone. And I think their breathing exercises is not just Alom Vilom and Kapal Bharti that you're saying. There are a lot of other gentle breathing exercises which are done, which patients can easily do. And actually, if you practice it regularly, you can feel your heart rate slowing down right.
Yeah, the yoga involves some form of hyperventilation. So, is that dangerous in heart failure patients? That was on.
That's exactly the point. That's
Yeah.
exactly the point, that there is a hyperventilation phenomenon.
Not always, not in all exercises.
Now, I think apart from this yoga problem, I think the real challenge in India, like all of us face, would be that patients comes with an acute heart failure, maybe a second admission, he's in the ICU, next day he's better, he's decongested, he goes to the ward. And today, with the intense pressure of beds from the COVID side, what happens in a day or two, once he's little ambulated, goes to the restroom, he's fine, he goes home, right? So actually, in most of our centers, we don't really advise them on to the amount of exercise, uh, leave supervised exercise that is non-existent in India. Okay, most hospitals, middle-level hospitals, would treat them in intensive care, go to the room. Once they're better, they go home. Okay, they are on all maybe 3 or 4 drugs. We very rarely do a supervised exercise test every visit and ask them as to how to build up their. I mean, we might casually say, don't go to office or just go and sit quiet and don't do. So I think Professor Coates' talk has been very nice, and I think we should, all of us should spend more time on teaching the patient how to do exercise and how to take it forward, because even the frailest of the frail patients tends to improve.
Yeah, and heart failure nurses and rehabilitation support staff would be very valuable. There's a lot of unknowns. There's fear. People feel they shouldn't exercise. The wife or the husband may be terrified whenever they do any exercise, and we need to demonstrate it's safe.
Yeah, do small weight training helps these patients, as Dr. Coates has mentioned, especially when movement is limited in this COVID situation. So small weight training, how much would it help?
I think, I mean, we all know that skeletal muscle loss is poor for symptoms and actually very bad for prognosis. So you want to avoid very wasted muscle, and excessive weight loss in heart failure is harmful.
Normal care level is less than 0.5. So, in spite of that, there are so many high.
Please mute Sandeep.
Sandeep, Dr. Bensal, can you mute?
Dr. Coates, another thing would be, as you rightly said, that family is terrified. Probably psychological support is also very important in these people to help them start at least an exercise program.
Yeah, I think support is essential. Exercise is a mood enhancing thing, as we've heard from yoga and other things. And consistently we see that anxiety and depression scores improve with regular exercise. So I think there are a lot of other benefits that we could achieve.
And that's where the role for supervised exercise program comes in, because if the patient is able to do those exercises in the hospital, you make them climb a set of stairs up and down, and then they monitor their heart rate and blood pressure, and that gives a lot of confidence to the patient that I can do this here, then I can do this at home also.
Yeah.
Apart from exercise, I think exercise is often coupled with nutrition, because if you want to overcome frailty, which is a problem for both wide implantation and transplant, you need a combination of the right nutrition together with exercise. Only that will help to build a muscle.
Yes, you certainly need to look after the patient, the whole life, all the lifestyle.
The other end of the spectrum are patients, young patients of heart failure, who try to prove to themselves that they're fine. They go home and quickly overexert and come back with another pulmonary edema. So I think that needs to also be, because we see quite a few youngsters who post MI undetected with heart failure. When they go home, you tell them as to how much of exercise. They try to show them, they'll say, no, I went back walking 1.5 kilometers, and at the end of it, they get dyspneic. So I think we should be very clear, and unfortunately, most of us are even not sure as to how much of exercise should the patient do.
I often get asked by a patient, how much can I do? And I say, you can do anything as long as it's only 10% more than you did last week. So you build up to it slowly. You don't suddenly go for a high level exercise, but you can do whatever you like as long as you do some amount, then you do 10% more, and then 10% more, slowly build it up. That's key.
That's pretty useful.
Yeah.
Hey, Tiny, if I may ask you a question, the results of Paradise are not yet out, and so does it mean that for patients with acute MI, we have to go from ACE to ARNI, or are we already there?
Uh, no, I
Like,
believe probably as we are getting more and more experienced, we might straight away go to ARNI. A transition shows that it is safe. And as time passes, more and more patients are right now on first hospitalization ARNI. And I think it is safe. But then the question is, once the SGLT inhibitors have come in, we have an option of whether to put patients on SGLT first and ARNI first. Now, anyway, beta blocker is first, no doubt about it. And after that, it practically to the bedside, instituting an SGLT inhibitor looks far more easier than putting an ARNI. Okay, so probably a RAS inhibitor, we're not talking about ARNI, and an SGLT inhibitor, and then change over the RAS inhibitor graduate to ARNI would be an option.
Dr. Coates was saying something. Dr.
Yeah,
Coates.
so I was going to give you an update. Just an hour or two ago, I saw a Twitter message from Pardeep Jun from Glasgow saying that they'd received a letter that the Paradise MI study was not positive. It was trending in the right direction, but wasn't significant. So it's on the web. It hasn't been an official announcement yet, but I suspect that's very soon.
that's very disappointing, I think.
It's disappointing, yes. So I have no detail. It'll come up at the ACC. But if you Google Paradise MI and June, you'll find the message.
I'm sure they'll
So
find subgroups.
So it would be beta blockade plus SGLTs. And
Well, of course, it was
ARNI later.
comparison. I mean, I think the difference is Paradise MI was sacubitril/valsartan versus Ramipril, but it was Ramipril 10 milligrams a day. So it was up against a very high dose of a very effective ACE inhibitor. So it's not as if it's against no treatment. It's against a very effective treatment. And apparently it was slightly better, just not statistically significantly so.
See, this also reinforces the point that Dr. Nair was mentioning. In our resource constrained economy, many times it's not possible to have people on ARNI. So I think it gives another shot in the arm that, if you can't use that, use good dose of ACE inhibitors.
Correct.
The results are going to be good in that case also.
So we have some questions that have come in.
Yeah. So, Professor Coates, what exercise protocols would you like to use in heart failure?
Okay. The most commonly one used is aerobic, so that's dynamic exercise. And we started with bicycle training, but you can also do jogging and gentle lifting, movement exercises. But there is also interest in some limited amounts of isometric or strength training exercises. And the best exercise protocol seems to be one that alternates more intense with lighter loads, so on-off exercise. The ideal duration is between 20 minutes and up to 40 minutes, and you want to do it between 3 and 5 days a week. Then there are other more sophisticated forms of exercise in particular patient groups if there's respiratory muscle weakness, but the majority would be combination of cycling or calisthenics and a little bit of strength training.
Right.
Can this 30 minutes be split into 2 or 3?
Yes, it can. It can. Yeah, and for a more frail patient, you can break it down. You don't need to exercise the whole body at the time. You can do limb by limb. You can do one arm, one leg. So if a person's extremely limited cardiac function, you can get muscle effects without putting a strain on the heart.
But the bar of doing 10 minutes at one stretch, I hope that stays, because this is a general saying that any exercise which is less than 10 minutes at a stretch doesn't add much to your activity. as in your total exercise for the particular day. So, does that figure of 10 minutes stay, or um,
Well,
any activity is better?
yeah, it's not been subject to rigorous testing, but I think the whole session should last 20 minutes, half an hour.
Right.
But it does appear that the best form of exercise is little spurts. So you might sort of do fast walking for 30 seconds or a minute, and then slow walking for 1 minute. So you're not completely stopping, you're just doing little bursts. That seems to be the optimal.
Right.
Dr. Sandeep, possibly that 10-minute bar is for healthy individuals and not for heart failure individuals. It depends. The baseline, a person with gross heart failure or decompensated heart failure may find it very difficult to exercise for even 2 minutes or 5 minutes.
Yeah.
So that bar.
Something is better than nothing.
Yeah.
That's probably the easiest way to do it.
Okay, got it. Could we have the other questions, please?
I saw one question that was on how long should we continue MRA in HFrEF? I think the simple answer would be we should continuously give it and not stop it logically. But then there's a small twist to the story because the recent sub-analysis of EMPEROR showed that if you analyze the data of SGLT inhibitors with and without MRA, you see that they're almost similar. So which means that even in the absence of MRA, SGLT plus a RAS inhibitor may be as good in preventing remodeling, whatever you talk about. So that brings into a question that in the long run, once that SGLT inhibitors are on board along with a RAS inhibition and a beta blockade, can we kind of after a period of time switch off MRA? And the answer is not known. But right at the moment, we should say that if a patient is stable on MRA, do continue MRA because MRA's effect would be preventing myocardial fibrosis. And if that is true, it has to be continued for a long period of time.
Tiny. So that brings up to a point that will SGLT2 inhibitors have the same impact irrespective of MRAs? Where do you put MRAs really? What do you say? How robust they are in terms of initiating or escalating before anything else?
See, like most of us are very strong believers of MRA, where we believe that to be active, MRA needs to be started early. In fact, we have data that if we start very early in a large MI, eplerenone gives good long-term results. And probably there's no point in starting MRA in a fibrotic end-stage heart failure, where it would probably add only in preventing salt and water retention. If you're looking at myocardial fibrosis, it needs to be started early. Now, this data is new, which looked into absence and presence of MRA on top of SGLT inhibitors, where they're very clearly SGLT inhibitors on board, MRA yes or no did not make a difference in the outcome. But does it practically come to a situation where we can avoid an MRA is not really very clear. Right at the moment, I think we should go with all four because all four have different mechanism of action. A beta blockade to start with, piggybacked on RAS inhibition. Best of it would be an ARNI, a MRA, and an SGLT inhibitor. There are two more questions on strain imaging to be done when considering de-escalation. The simple answer is no, because the data that we have in TED heart failure, very clearly patients had all the hemodynamics normalized, and on withdrawal, their hemodynamics worsened, their biomarkers went up. So at this point, we don't have data as to any particular imaging, whether it is strain imaging or MRI, cardiac MR, would tell us that this is a patient where you can de-escalate. Right now, it would be good not to de-escalate unless you have a very specific patient who is developing side effects on a particular medication. You want to come down on dosage, which is not de-escalation, but optimizing dosage. But right at the moment, there are no tools to tell us that this patient is safe for de-escalation. That would be my take. Professor Coates, any opinion on that?
No, I think you summarized it very well.
One question, how about adding 6-minute walk test in the card? Dr. Coates,
I'm not sure what means in the card.
in the card is that card that I showed. There's a
Oh,
paper
yeah, yeah.
card. It's given to the patient at discharge.
I think we should do more regular monitoring of our patients. And the two things we don't do is any form of exercise assessment. And I think 6-minute walk test is quite a good one. But also, I think we honestly should do something like KCCQ on a regular basis, because we just ask the patient how they're feeling, and we often get a misleading answer, not too bad. And I think we probably need some objective evidence whether the patient is getting better or worse.
Yeah. Actually, talking of cost effectiveness, KCCQ is extremely costly to use. So, but there are other scores.
There are others. KCCQ is complicated, but even global assessment, we probably should do some simplified version.
Yeah. What are some health measures? I don't think this is related to today's topic, but there is one question as to what are some health measures that should be taken by heart patients during the COVID pandemic. I don't know who can take that.
No, I think it's not relevant to our discussion.
Yeah, this is not relevant to the present discussion. Suffice to say that if you're in an ACE inhibitor or ARB, please do not stop it. Please do not stop your aspirin also. Continue to take it. And do take, your doctor will give you low molecular weight heparin and steroids as needed. And also, if your D-dimer is high, you need to be on a NOAC for a variable length of time. So those would be kind of recommendations relevant to cardiology, I would say, offhand recommendations. Can we have more questions, please? Yeah, so it has been said that MRA should be added in EF less than 40% in anterior wall MI. The European Society guidelines says to add below 35%. What to follow? Tiny, would you?
I think we should not just follow an ejection fraction in deciding on MRA. Like we said, the concept today is that when we are looking at these 4 drugs, MRA, beta blockade, RAS inhibition, and an SGLT inhibitors, each of them individually improve outcome, better survival. So we are not just looking at a cutoff point of ejection fraction, despite the fact that knowing today that some of these therapies are ejection fraction dependent, and some of them are independent of whatever be the ejection fraction. But I would say if you're looking at a cutoff of ejection fraction, anything below 40, you should probably put on an MRA.
Great. Okay. Fine.
I don't know, like to.
Any relationship?
Yes.
Spironolactone 25 milligrams per day is good enough. Unfortunately, pharma company, this is just an opinion. Okay, right. Any relationship between diuretic reduction, the percentage while starting SGLT2 inhibitor? Yes, this is important that because by its nature of action, SGLT inhibitors are a bit of diuretic. And so we might have to de-escalate diuretic dose. When we are talking about de-escalation of drug, we don't include diuretics, understand that. We are talking about foundational therapies that in the long run alter survival or reduce mortality. That is beta blockers, RAS inhibitors including ARNI, SGLT inhibitors, and MRAs. So when we are talking about de-escalation, we are talking about de-escalation of those. There, diuretics don't come in. The moment your patient is decongested, diuretics should be out because no diuretic trial in the long run has shown that it saves life. You can always argue that it's like in parachute. There is no trial to show that parachute saves life. If you don't give a diuretic, a patient who is coming to the hospital might actually die of a pulmonary edema. That's not the point. In the long run, chronic diuretics have not shown to improve survival. So they don't come into escalation, de-escalation. De-escalation has to be done for diuretics, especially when you add up SGLT inhibitors. Otherwise, you might end up with significant hypotension and dehydration.
Dr. Coates, let me go back to the previous question. Is there any data to suggest that 50 milligrams of spironolactone works better than 25 milligrams?
No.
No, I mean, we don't really have good dose response in anything, and particularly MRA. It's only 25, 50. The Americans use 25, Europeans suggest possibly 50. Honestly, when they started the rail study, they were thinking of investigating up to 450 milligrams, and they found that they had a lot of benefit at 25 and 50. So to be honest, for MRA, there doesn't appear to be a dose response for the benefits.
Yeah, regarding MRI in Indian settings, I think eplerenone is 16 times costlier than spironolactone. So I think the side effects will be of estrogen related in around 10% of the patients. Probably if you look at the cost effectiveness, I think we should start on spironolactone, and if there is a problem, then we can shift to eplerenone.
A small addendum to what Professor Coates just said. You see, in the RALS trial, while there was no added benefit of escalating the dose, the side effects would increase. So between 25 and 50 also, the incidence of hyperkalemia was higher if you gave a 50 milligrams. And that is how perhaps the origin of the question also, because the efficacy doesn't change, but the hyperkalemia incidence increases if you go beyond 25. Nonetheless, we are practicing the way we are practicing. This is, I think, no longer a very valid question in wake of the recent trials. But maybe Tiny, you'd like to say anything? There is Vishal, you can take it, or Hari or Bani.
Yes, so all of us have prescribed SGLT2 inhibitors in non-diabetic patients. We routinely prescribe SGLT2 inhibitors to our heart failure patients, irrespective of their diabetes status.
I should say, I would say we should prescribe.
All of us do, yeah.
Yes. The next question, if you could display.
Which beta blocker?
Yeah, which beta blocker to prefer? Again, Tiny, maybe you would like to take this.
No, I think these are the three beta blockers which have been shown to be beneficial in heart failure: metoprolol, succinate, bisoprolol, and carvedilol. And we should use only those. Nebivolol has been shown to be beneficial in seniors trial, but there was no mortality benefit. So we should restrict ourselves to the three beta blockers they are shown. Between these three, probably it is your personal choice, depending on the kind of patient you are dealing with. A patient who has perhaps bronchospasm, or you want to use a highly beta selective beta blocker, you would go for an bisoprolol. A patient who is hemodynamic compromised, the lowest possible dose of a beta blocker you can start would be a 3.125 milligrams of carvedilol. And the general trend would be a patient who has a coronary artery disease. Because of our years of training, right from our medical school days, we are on metoprolol for coronary artery disease, tends to get metoprolol. I mean, that's the general practice. If you have a coronary artery disease and heart failure, tends to go on metoprolol. Sensitive patients go on bisoprolol, and maybe hemodynamic, you start with a very small dose of carvedilol. But we should know that there are no head-to-head trials, and all three beta blockers are good enough.
And the long-term, long-acting metoprolol only should be given.
Yeah, succinate. The question said succinate.
Succinate. And any experience on this long-acting carvedilol? Is it equally compared with once a day carvedilol? Any experience?
The long-acting carvedilol is good for hypertension, but I'm not sure about quite a few patients we have changed over, those who had been taking carvedilol, but studies I'm not sure. It's convenient, yes, obviously.
Regarding the follow-up, as Dr. Tiny has mentioned, the first week follow-up at day 7 or just after the first week has been shown to significantly reduce mortality in patients. So if our patients, if we can plan a follow-up just in the first week itself, I think it is said that it will improve the outcome. So it is a simple thing which we can be done. Even a telephonic follow-up would help.
In general, our patients come for a follow-up a lot more than what they would do in West, because their follow-up, I mean, I don't mean the first follow-up, but subsequently they may be seeing them in 3 months or 6 months' time, while our patients tend to come up every month or 2 months for their checkup.
Dr. Coates, what is your practice when a patient is discharged after an acute decompensation? What is your follow-up pattern?
Yep. I mean, it does depend on the circumstance. I mean, we get patients from a long way away, so we often have to share care with the more local hospitals. But I really like heart failure specialist nurses and outreach clinics. So I like to have the patient feel that they can contact the heart failure clinic whenever they want. I will only want to see them every 3 months or even every 6 months, but I would like to have more regular contact through the heart failure nurses.
See, that is because heart failure nurses and your these ancillary programs are lot better developed than what we have.
Yeah. Yeah, different healthcare system, but it's very effective, and nurses are more careful, and the patients listen to them more than they do doctors, strangely enough. So they can actually get up titration, they can get adherence to exercise better than we can.
Okay.
Any other
Shall we move
questions?
on?
No, sir. No more questions, sir.
Okay.
So I think we have to go to the pre-test recap or something.
Yeah, I think
discussion points.
Yeah, Bhagirath, are we having the recap, or are we all, have we discussed most of the points?
I think we are done. We are done. We
Panel
can
discussion,
go
few
with
points. I made a few slides.
You can just read out the slides.
I'll read out the slides and yeah.
I'll do that.
Messages we don't need to discuss.
Yeah.
So I think first thing would be an update on various registries regarding the heart failure burden in India. I think this was part of Dr. Hari's talk. So would you like to make a comment?
Yeah, as you have written, we don't have a real data on incidence or prevalence, but the Trivandrum registry, as Dr. Tiny has said, only 25% of the patients received guideline-directed therapy. But recently, the National Heart Failure Registry has improved to 40%. They will come data, and we have to take measures to improve the accessibility, availability, and affordability of these therapies. Many of the things which we have discussed today. And as discussed, we should have a bioprofiling to customize the heart failure treatment in this patient. Each patient is different, and we have to individualize the treatment in these patients and plan the follow-up and the therapy in those patients. Yeah.
Another point was to include artificial intelligence, AI, so that points are not missed on follow-up. It's an automatic flow chart and a check protocol to make sure that every detail is attended to. The other thing is utility of 6-minute walk test. I think we already dwelt on this point today. Role of devices, I think also extensively discussed. MitraClip and that is the MitraClip FR and the COAPT data that also has been discussed, and we know that the selection criteria for both the trials were slightly different, and that's why the difference in data. And we had a good discussion on the remedy device for sleep apnea. I think this is very relevant because many patients have this problem which is often not diagnosed or underdiagnosed. An important point was the intraatrial shunt devices for heart failure with preserved ejection fraction, because this is one area where we don't have much other than diuretics in terms of management. So this may play a role in the near future. Just wanted the opinion of the House regarding this. Dr. Coates?
Interatrial shunt devices, any?
Intratracheal shunt devices.
Yeah, devices are an extremely important part, and as you say, we obviously have standard ICD and CRT, but now with comorbidities, they're becoming increasingly important. The role of MitraClip, it has a role in particular patients, mainly with the Abbott, but there's also the developing device from Cardiac Dimensions, the Carolyn device that might be useful in more mild MR. The sleep apnea is extremely common, and if it's central sleep apnea, we can't use the positive pressure airway mask. So the Remedy phrenic nerve stimulator definitely improves quality of sleep and seems to have a beneficial effect on left ventricular function. I think the story is too early for the intraatrial shunt devices, but it can improve the physiology. So we're waiting on some more trials to come in that way. And of course, we're continuing to see improvements in mechanical circulatory support with better and better ventricular assist devices, but it's still a very small option for many of our patients. I personally think devices will come. The one I would add to that is, the cardiac contractility modulation, I think, does improve exercise tolerance, but particularly where the ejection fraction is not too low. So the sweet spot might be between 25 and 45%. But there's also the Barostim device from CVRX that improves sympathovagal balance that's got approval from the FDA, breakthrough approval. And I think we'll see quite a bit more of autonomic function modulation with electrotherapeutics in the future.
Thank you.
Okay, some passing mention on high-risk valve surgery by Dr. Sundar and high-risk CABG surgery, because revascularization improves survival, but again, you have the nightmare of losing the patient if such surgeries are attempted. Also, the counseling for heart transplant has to start in the management of heart failure pretty early. Peripartum cardiomyopathy and subsequent pregnancies, I think a lot was discussed on this, as which category would you allow, or would it be a blanket no for all of them? This, I think, was very eloquently discussed by Dr. Rambuj in saying that those who had a normalized EF, they can have a multidisciplinary evaluation and then decide on subsequent pregnancy, whereas those who did not recover should strictly follow contraception and should not have subsequent pregnancies. Another important topic was the tachycardiomyopathy. How do you identify, how do you treat, when does it happen? That is heart failure, heart rate more than 100 per minute lasting more than 10 to 15% of each day, and atrial rate more than 150%. So not every patient, oftentimes we find patients with atrial fibrillation who also have LV dysfunction. Same chicken and egg story. Which one came first? Atrial fibrillation caused heart failure, or heart failure caused atrial fibrillation? So these are the criteria to differentiate between the two. And also an important topic that was discussed was PVCs and heart failure. When would you treat? When would you ignore? When you would be alerted? I think Professor Samuel Ashirvadam's paper saying more than 20,000 VPCs in a young individual should definitely alert you in terms of management, and also a 16 to 24% incidence in the Holter. Next up was a very important topic: how to manage chemotherapy induced heart failure. When would you reduce the dosage? When would you modify the dosage? When would you continue, and how frequently these patients should be followed up? I think that's also been extensively discussed. Iron therapy with or without anemia to treat heart failure, just like the SGLT2 with or without diabetes. Again, a very important point that was discussed in detail. Treatment of diabetic cardiomyopathy, guideline-directed therapy with SGLT2 inhibitors is the way forward. This would be the way in which the guidelines would prescribe treatment. Management of high-risk COVID heart failure, I think this was brought up in the chat box. This also was discussed extensively last week. SGLT2 is useful in diabetic as well as non-diabetic heart failure. And an important point was management of severe tricuspid valve regurgitation. When would you advise surgery? When you would not? We all know that the surgical mortality is upwards of 25%. Percutaneous devices are coming up in a big way. You have IVC based device, percutaneous tricuspid valve replacement, percutaneous tricuspid valve repair, annuloplasty rings that are available, which can be inserted percutaneously. So these would alter the profile and prognosis of such patients.
Okay, I think that probably completes the academic program for the day. And now I think it is time for the test, which who's going to? Hari? Time for the test?
Yeah, it is now it is time for the test. Before that, I thank all the faculty who has been part of this course. I thank Dr. Andrew Coates and the Heart Failure Association of the ESC being part of this academic initiative. We had a very good 6 days of program, and even in the very grim situation of COVID, we could do this course and complete it. And now we will go on to the post test. The post test, we will have 25 questions, and there will be it will be multiple choice questions. And once you start answering, the correct answer will be shown in green, and the wrong answer will be shown in red. So once you attempt the 25 questions, and if you score more than uh, 20 questions correct, you will get the certificate. So if you if you are not able to get it the first time, you can go through the answers and retake the test and get the certificate the second time. So all your emails will we have sent the instructions and the link to the emails of all the participants. So you can click on that and start taking the test. So we will show if any of you have not received the link, we will an email address will be shown. You can send an email to this address, and you will get a reply with the link. So if you have any doubts, you can contact the particular email. Anand, can you show your email?
Sir, coming in, sir.
Yeah. Dr. Chopra, can you say?
No, I think it has been a wonderful 6 day session, and all thanks to the Heart Failure Association and especially our guest speakers, Dr. Andrew Coates, Dr. Rosano, and Dr. Anker, and so many other faculty who participated in this. I'm sure all of us learned a lot. It's not that sitting on this side we don't learn, and it's the listeners who are learning. Each of these sessions teaches us a lot. So with that, I would like to thank all the speakers, all the chairpersons, and the panelists for a wonderful 6 days of academic activity. We'll be taking a break from these because till this madness of COVID gets over, then we will be resuming our academic activities again. Thank you.
Yeah, Uday, yeah.
Thank you very much, Vijay and Hari Krishnan, for, as always, for the encouragement, Professor Dr. Andrew Coates, Stefan, Professor Rosano, to help us out in this meeting. And it's been a fantastic sessions all through. It's a lot of learning, a lot of new things. Paradise MI, the Twitter, you'll just...
Yes, look up the Twitter.
so very new to us straight away. And so thank you everyone. Bhagirath, it's been fantastic helping us out, and our Vinay and Anand Peter. Sun Pharmaceuticals has been working hard now to see that they remain associated with us for the future heart failure program. So thank you once again, and let's move on for the further session.
So thank you everyone, and good night. Thank you, Dr. Coates, once again. Yeah.
Thank you.
Pleasure.
So much.
Thank you. Good.
Are we off air or on air?